Thank you. I now welcome Professor Miri Forbes and representatives from Lifeblood Australia by teleconference. I understand that information on parliamentary privilege and the protection of witnesses giving evidence to Senate committees has been provided to you. For the Hansard record, will you please state your full names and the capacity in which you appear today?
I can kick off. So my name's Joanne Pink. I'm the Chief Medical Officer for Australian Red Cross Lifeblood. And obviously Lifeblood does collect blood and plasma for Australia, and my role primarily is looking after the medical aspects, so donor safety and product safety.
Thank you. We're still waiting. And we understand that Dr. Pink, Professor Pink is coming online, and Professor Forbes. So we shall expect them to join shortly. I now invite you to make a short opening statement, and at the conclusion of any remarks, I will invite members of the committee to ask questions. So, Professor Pink.
Thanks very much, Senator. People donate blood to help others, and our priority at Lifeblood is safety and sufficiency of the blood supply, as well as having rules in place to make it safe for donors to donate. Donors must feel healthy and well and meet a number of health requirements in order to donate blood. And as you're aware, the May 2025 ABS report on PFAS demonstrated that most people would have some amount of PFAS in their blood, and that PFAS levels are generally higher for older age groups and generally higher in males. Lifeblood does not have a specific published PFAS level where a donor will be deferred from donating because there's no known level where there's a risk from blood transfusion. Our policy is consistent with the practice of international blood services such as the UK, Canada, Netherlands, Japan, American Blood Services and others. Only a small percentage of blood is removed during blood donation, and then what we do is we split the different blood donations into different components so that the amount of PFAS in any single blood component is minimal. About 560,000 people in Australia regularly donate blood or plasma, and whilst we have good representation from all age groups who are older than 18 years, 18 years is the minimum age limit for a blood donor, our older donors do give more frequently and they provide a greater contribution to the overall blood supply. And this includes great support from donors from our emergency services. In fact, last week we kicked off our annual Emergency Services Blood Challenge, which runs for 3 months. And most of our first responders, including state fire services, country fire services, police and ambulance, are encouraged to donate. There is some evidence that indicates, as you mentioned, that blood or plasma donations may reduce PFAS concentration levels in the blood at a faster rate than is naturally eliminated from the body. And for this reason, the provision of a service to enable people with high PFAS levels to donate blood or plasma to specifically reduce their PFAS levels in order for them to gain a health benefit has been raised. And this is called a PFAS therapeutic blood collection program. Lifeblood doesn't provide such a program because there's no clinical evidence that reducing PFAS levels in blood is associated with better health outcomes. And to my knowledge, no international blood services also provide a PFAS therapeutic blood collection service for the same reason. But Lifeblood is continuing to monitor scientific evidence and developments to ensure our policy remains in line with current evidence and international practice. And if required, we'll consult with the National Blood Authority and the TGA about changing our policy.
Thank you,
Thank
Dr.
you.
Pink. Professor Forbes, do you have an opening statement?
Hi, I do.
Welcome.
I guess I don't have a formal written statement prepared, but I'm excited to be able to present on behalf of our team at Macquarie, who worked in partnership with Fire and Rescue Victoria to run this study that looked at the efficacy of blood and plasma donations to reduce serum PFAS levels. So we had 285 FRV staff participate. We had a lot of interest and incredible engagement. We had, I think, 92% retention over a pretty hard slog of a study protocol for participants to engage in. And we found that both blood and plasma removal were effective at reducing serum PFAS. Plasma was more effective than blood. And so that's the first time that anyone has found an intervention that can effectively reduce PFAS levels for people who have had occupational exposure, for example, in our study. And so we thought that it was relevant potentially for consideration as part of a management strategy that could be made available. I just caught the tail end of the previous statement about the idea of therapeutic donations for people who wouldn't otherwise be eligible to do blood or plasma donation. And mostly I was here to hopefully answer any questions that I can to clarify the results of the study and speak to them here.
Thank you very much. I'll hand over to Senator Pratt.
Thank you. Thank you for the enormous work you do in supporting Australia's blood products supply. And you're predominantly people do donate blood in order to help others, but we've certainly had evidence that says their motivation for donating plasma and blood is to lower the PFAS levels in their blood. Have you sought to look at the motivation of first responders when it comes to these issues? And they're not necessarily separate, but and I know we rely on communities of people. Do you see it as a win-win, despite the fact that they've got high levels of PFAS, because it provides a motivation for people to donate plasma? Or how are you dealing with that question?
So we do a lot of research on what motivates donors to donate. And as you know, in Australia, it is a voluntary system. And as you say, it is primarily about wanting to help people, others, rather than donating for a specific health benefit. Clearly, when people donate, you do have that good feeling about helping others. Maybe I can give an example of another program that we do have for therapeutic donors, and that is a program for hemochromatosis donors. Hemochromatosis is a condition where your body absorbs too much iron, and there is a lot of iron in red cells. So essentially the treatment is actually donating blood regularly. So for that program, we have two separate arms, because clearly when donors come in, they have to complete a whole lot of questions, and the purpose of the questions is to ensure that it is safe for the donor to give blood, but also that it's safe for us to transfuse the blood as well. We do screen the blood, as one of the other speakers said, for a range of infectious markers, but no test is perfect. So what we do for the hemochromatosis donors is that we provide two different programs. So there is, if you do otherwise meet all of our donor eligibility criteria, then we are able to use your blood and it can be transfused. But we also provide another pathway, and this is where the donors can come along and have their blood collected, but we discard that blood. It's not used clinically. And that's a very important arm when you're looking at therapeutic blood donation, because you want to make sure that the donor discloses all of their risk factors, which may actually have a risk from a blood safety perspective. And of course, we're only able to collect blood from donors that are well enough to come to our blood collection centres. And so, if someone is unwell with hemochromatosis, then they need to go to their GP or a hospital to have the blood collected. Yeah. So that's sort of like an example of therapeutic blood collection.
So absolutely. But you have a science behind that, and so you expect people to disclose that, but you don't require people, even in occupations where there is a likelihood of elevated PFAS, to disclose that. Is that correct?
That's correct. Our policy is that...
I understand the policy. So in turn, the medical researcher and paediatrician before us said he understands because you need these products that you'd prefer to, have plasma than no plasma, and therefore not to care whether it's got PFAS in it or not. But in his evidence, he also said no one's got 0 levels of PFAS in their blood, but that's what biologically we should be. So surely in that context, in the long term, that requirement for disclosure and surveillance in the long term, even if it is simply a disclosure, I presume you track whose blood went where to which patient in the long term. So if it is simply a matter of disclosure, why are you not, as a first step, requiring that, particularly when we've got large cohorts of donors in a particular pool who may have elevated PFAS exposure?
Yeah, that's a good question. So just with regards to tracking the blood, to start off with, Lifeblood has very comprehensive computer systems, and we track it to the hospital. So we do not track it to the individual patient. So that would be the responsibility of the hospital. For monitoring PFAS levels, I think, all of the speakers, it's been great to monitor it at a population health level to see and it's really reassuring to see the levels coming down. We have looked at, our policy with regards to should you have a cutoff for PFAS levels. And the challenge for that is that, as you would have read in the May 2025 ABS report, essentially 85% or more of the population have got PFAS levels.
Yeah, but they also, the scientists have also said that we need more data, and so couldn't a program like yours, through disclosure and understanding of occupational risk, get that blood tested and provide that data to underpin that science?
I think if government wanted to set up a screening of blood donors, as an example, as one of the surveillance programs, that's certainly something that we could discuss with the National Blood Authority and the TGA.
And in that context, you could take a cohort of all donors and a cohort of those in high risk, or even all people in high risk exposure professions.
Certainly, Lifeblood is interested in working with government from a surveillance perspective, and where, we've had roles in the past with looking at COVID and all those other things. So if the question is Lifeblood interested in doing surveillance of blood donors, that is something that we could discuss with the National Blood Authority and the TGA.
And what kind of surveillance do you already assist with? You gave the example of COVID. It would be good to hear other research that you're involved in.
So primarily the research, and we're hoping to work with the Australian CDC as well on this. It is a key role that we think we can play in surveillance because, as you are aware, blood donors are well and healthy, which is quite different to a hospital population because they go along because they're ill. And so it's particularly relevant for conditions where the person can feel completely well. For example, for infections like JEV, when we had the outbreak, we did a similar study because it's nice to see which people have been exposed but are completely well, because otherwise you just see the tip of the iceberg. So that is something that we are interested in expanding. So at the moment we've done COVID, JEV, we've done other studies like, for example, looking at measles immunity in donors because, that's an emerging infectious disease and it really helps inform immunisation programs and, just all the different strategies. So Lifeblood is very interested.
With PFAS might actually be really interesting because of the immunity implications on putting down, reducing your immunity if you have high levels of PFAS. So there might be some good combinations there.
Yeah. The $64 question is obviously funding these things. So that's one of the reasons we would need to, get support from government to do that. But from a general surveillance perspective, that is one of the strategies that Lifeblood is, very interested in helping government with.
And would there be cost efficiencies in making sure that people asking for this kind of surveillance science are pulling together this, the cohorts of people, and we're just taking, if you're taking blood, that we're able to, test it for more than one thing as part of that study to reduce costs? Is that something you've considered before?
So we have worked with other groups because, as you know, the Australian population is much broader than blood donors. There's pregnant women, there's people who are ill. So we have worked with other partners as part of the COVID study so that we have great representation across Australia. So certainly...
And what about those other partners being part of multiple studies? I think as a politician... I've been on lots of inquiries where you have different health communities say, please test for this, please test for that. And of course, there's a budget's required for all of those things.
That's right.
And it would be great to see stakeholders work together to ask for things in common to put efficiencies inside that surveillance system.
Yeah, I agree with you because, as I said, there are different population cohorts across Australia, and different organisations have different reaches into those population groups. So our real strength is the healthy population that are aged 18 years and older, because we don't collect blood from people who are younger than 18 years.
Thank you.
Thank you, Senator Pratt. Dr. Pink, in your opinion, what should ideally happen to PFAS-contaminated blood? Should it be dumped? And if so, should it be destroyed, such as through thermal destruction to ensure PFAS doesn't keep circulating in the environment?
So to date, the evidence on the health impacts of PFAS, as you know, is uncertain, and it's great to see this Senate Select Committee looking at PFAS. The levels are reducing in the community, and I think...
sorry, Dr. Pink, we've been hearing all morning about the evidence, the health impacts of PFAS, and we were told not to accept those kinds of responses. So if we can just keep that in mind, that there is evidence, there's actually insurmountable evidence on the health impacts of PFAS. So, the blood is important, and what happens to the contaminated blood is also important.
And the Health Department's own national Australian website, our own Health Department's website, acknowledges there are health impacts. So I guess as a blood agency, I
think, as I said at the beginning, it's both safety and sufficiency of the blood supply. And because we know that just about everyone will have a level of PFAS in their blood supply, in their blood, it's challenging to say, well, at what level do you say blood is unsafe? Yeah. There are a lot of things that we do to minimise exposure, because the blood donations are split, as I said, into different components, and we use, non-plasma additive solutions. So I think one of my concerns is if we did say, hey, this particular level of PFAS is not safe and we need to throw out the blood, then I think that we would run into significant sufficiency issues, and not having enough blood is a safety issue for patients. So Australia has got one of the safest blood supplies in the world, and we're really proud about that. But that doesn't mean that there is no risk of complications from having a blood transfusion. And so from a clinical perspective, when a doctor is prescribing a blood transfusion for a patient, they go through all of the potential complications, and they make a decision together with the patient whether the benefit of the blood transfusion outweighs the risks. And I think that will always have to continue, because even though, as I said, Australia has, one of the safest blood supplies in the world, and, we're very well supported by government, there will never, it does not mean that you can guarantee safety 100%. So I think from PFAS, because PFAS is so widespread, unfortunately, if we were to say this limit is going to be the cutoff, one of the particular challenges for us is that we have a number of different donor cohorts, but we know that our older donors, and the evidence has shown from that ABS report that the older donors in general have a higher level of PFAS in their blood compared with younger donors, and particularly males. Because our older donors contribute more greatly to the blood supply, if we were to have a cut-off, that would bring, significant risks of insufficiency of the blood supply. That's the challenge. And I'll give you an example. We do marketing for different cohorts of our donors. And I'll give you an example of our apheresis ACEs. Now, these are donors that donate plasma quite frequently. They account for about 3% of our panel, but they contribute about 14% of the total blood supply. And their average age is in the order of 56. I haven't got the data in front of me, and they're primarily males. So that just gives you a bit of context about, if we were to have a set level, how would we manage security of the blood supply? It's a challenge.
So hypothetically, Dr. Pink, if you were to receive blood supply from community at Wreck Bay, where there's a known cancer cluster from PFAS, and you gave that to a pregnant woman, we've heard evidence today that, fetuses are, more susceptible. Is that okay? Would that be okay?
So the evidence to date, as I said before, is because we collect the blood and we separate it into different components, the risk from one single blood component is minimal. And as I said before, you need to balance sufficiency with safety. It's really the nub of blood donation. If we had a policy where we were incredibly restrictive and you were trying to eliminate, a whole lot of different pathogens and other matters, we may be in a position where you have an ultra safe blood supply, but there's not enough to go around. And so, in fact, the scale would be causing more harm because there's not enough blood to go around to meet the needs of patients. And I think that's really where we are with PFAS. It's because it's just so generalised at this point in time in the population, and I didn't hear the whole day, so I don't know if people are saying there's a specific level for PFAS. To my knowledge, there's not a specific level. It makes it really hard to balance having enough blood in the bank.
Well, I think from what we've found out in this inquiry is there is no safe level of PFAS in anyone. But we know water can be filtered for PFAS. Is it possible for blood to be filtered?
So there is filtering of plasma. So the plasma fractionators have a number of steps called pathogen activation or pathogen reduction. And one of those steps is called nanofiltration, which is exactly what you've said. It's just filtering out pathogens, because your proteins in your blood actually are very small, and they're much smaller than some of the pathogens like hepatitis B. So that is a step that they do use to filter out pathogens. But the PFAS molecules, I think, are quite small. So you would essentially filter out everything. So I don't think filtering per se to remove PFAS would be suitable for plasma. And then for red cells, they're actually quite big, red cells and platelets, so that filtering those products wouldn't actually work, unfortunately. Whether I heard the previous speaker about having some sort of absorption technology, which I don't know, to my knowledge, it doesn't exist, but, having something like that potentially would be suitable. But I think for all of these things, one of the challenges, again, is just the size of the health budget. And, we're in a position whereby you have to, if you're going to spend money on one particular thing, it means that another priority can't have money spent on it. But as I said before, we're very happy to work with government, with National Blood Authority and TGA, and take a different policy approach if that's what government wishes.
Great. Thank you. I just have one final question for you, Dr. Pink, and then I've got a number of questions for you, Professor Forbes. Doctor, has the federal government approached you to see if your organisation can support efforts to lower PFAS blood levels in highly affected populations?
To my knowledge, no.
Have you been approached by firefighting bodies or the UFU on this matter?
We have been, as I said before, approached by the firefighters to stand up a therapeutic blood donation program. And as I've said before, the current the decision to have such a program does not sit with Lifeblood. It is a decision that we would have to work in collaboration with the National Blood Authority and with the TGA.
Okay. Thank you very much. Professor Forbes, do you think additional evidence is required to justify a therapeutic blood donation program in relation to PFAS?
That's a really good question and probably goes beyond my specific expertise. I think that from our study didn't speak to the therapeutic benefit for the health markers that we looked at. They were secondary endpoints and we didn't observe significant change over the course of our study, but it wasn't designed to look at that question. I think that we would need to design studies that specifically recruit people who have elevated PFAS levels and the health conditions of interest to then look at, well, what's the effect if we can reduce those serum PFAS levels over time? How do we see changes in those health outcomes to speak confidently to them? So I think that I would say more evidence as a scientist is always preferable and it would be very welcome, I think, to have more evidence to be able to speak to that.
Thank you. Have you engaged with the Red Cross and the government around the benefits of blood donations, and what has your experience been in this regard?
No, we had some early contact in the planning of this study that I wasn't a particularly active member in. My role has been in the research methods and statistical analysis and reporting of the results, so I can definitely speak confidently to them. But we tried to stay in our lane in terms of focusing on what it was that the implications of our study found, which is that we can confidently infer that plasma and blood removal both result in the reductions of serum PFAS. And then I can hear in this discussion that the implications of that are a much bigger picture, separate to what we could speak to from the research that we conducted, thinking about the implications of those donations being in the blood and plasma supply and the role that therapeutic donations could play. But we can speak to this as an effective intervention that is available for reducing serum PFAS levels.
Why do you think this has not been pursued as an approach to lower PFAS health impacts?
I guess it's still pretty new in the research world. Oftentimes results to implementation is quite a long pipeline. And so I think that it's really exciting to know that this possibility is here, and to implement it in practice, there's a lot of steps from the knowledge that we can be confident it will be helpful to seeing it rolled out in the world. I think that having potentially stronger action from committees like this can really have an influence on that, seeing the change in the world, having government action and funding that is available to really support the changes that these committees recommend is, I think, the fastest path to seeing those changes. But it's not unusual in my experience of research and clinical trials to see that actually getting those interventions out in the world can take some time.
It seems like a lot of people are not aware of blood donations being a suitable option to reduce PFAS blood levels. What should be done to grow the awareness around this in government, the scientific community and the broader population?
That's an I think I would ask you that question in terms of where do you think the gaps are and what we can do to address them. I think that, from our perspective on the research side of this team, we really wanted to understand whether the evidence was there. And there was enormous media response. I can't remember the number, but there were hundreds of media articles and coverage internationally and in all the major outlets in Australia, a lot of coverage of this finding and result. I think it was really exciting to know that there are interventions that are available for these people who are affected and really distressed by occupational exposure or exposure in the areas that they live in. And so it made a big splash at the time, a couple of years ago now. And I think that, having people who work in implementation science who really have the knowledge and expertise of how to progress this in practice is an essential thing that isn't currently happening, to my knowledge, with this specific outcome.
And my final question, just going back to Wreck Bay, because I've visited that community, and it's a reason why we're having this Senate inquiry, because the Wreck Bay community asked for help, which they still don't have. No one will provide blood testing. They don't have a doctor that will... there's a doctor that goes there once a fortnight. There's some trust issues around, which doctors that they see to talk about PFAS and their diagnoses. I just wonder, out of interest, whether the Wreck Bay community kind of sparked some interest in your mind to do a study with, given they have a never-ending, growing concern and health impacts from PFAS. The cancer is real. We saw a snake dying on the beach affected by PFAS because that's where the water's running through to, and children with cancers, elders with cancers, and a cemetery, predominantly full of people that have died from these rare cancers. So just out of interest, because this community is crying out for help and no one will help them.
Yeah, that's a really distressing circumstance for the community. I think it comes down to funding, right? I think that given targeted funding for that kind of research, it wouldn't just be our team with existing interest in this area. There would be researchers all over Australia who would jump at the chance to help those communities and to really understand, try to strengthen our more causal inferences we can make about health impacts, and the health impacts of reducing PFAS in particular is something that I think we know very little about. We have more of that information on health outcomes that are associated with elevated levels of PFAS, but being able to look at things like, do these interventions meaningfully change the kinds of health markers that are important for the health impacts being observed in those communities? Ultimately, this study was funded by FRV, right? They're so passionate about this area and have such strong motivation to support their staff and find ways to be able to affect change in this space. They had more than $1 million of funding put into this for us to be able to follow these firefighters, conduct all of the blood testing and following them over time, the costs of running the trial. It wouldn't have happened without that. And so without those kinds of funding opportunities available to book in specific communities, the money just isn't there to be able to do it. And so I think that would be something that would be really exciting to see come out of this, is to have targeted funding available for that kind of work and in those communities. And with the funding available there would be a lot of different researchers from different backgrounds and with different ways of being able to contribute to these priorities that would jump at the chance to do that, I think.
Well, thank you both very much. It's been very informative. If you have undertaken to provide additional material on notice, please provide it to the Secretariat as soon as possible and no later than 5 p.m. Monday, 30 June 2025. Additionally, if you have further information you'd like to provide that you haven't been able to cover in this session, also please provide it. The more information we have, the better off we can have a report that has some teeth and hopefully some recommendations that we can implement. So thank you very much. We will now suspend for lunch and return at 1:30. Thank you.
Thanks very much.